Welcome back to the ANW Physical Therapy Podcast. I am super excited about what we have in store for today. We are going to be diving into a current patient case of mine so that I can start to present some very real life, very tangible examples of how the visceral work really works in the lives of the people that I treat in my practice. So if you listened along to the first episode, you know that I am super passionate about organ health, especially in the realm of the mobility of the organ systems and how everything kind of works and moves together so that it best supports the body. Ultimately, that's why I've pursued my specialty of visceral manipulation. So again, at the very brief intro into the visceral manipulation work, at its foundation, it's a gentle manual therapy technique that works to improve the mobility of organ systems to improve function. So everything needs to be able to move in order to function. And I truly don't think that there is a better way of explaining how the work works or how it impacts individuals. There's no better way than describing that than through patient cases. So with that being said, we are going to dive into, again, a patient case of mine. I'll start with a little bit of background and history and then dive into some of the evaluation that I completed. So some of the examination of the patient, some of the objective information that I gathered, and then diving into the treatment, what I worked on, and then we'll talk a little bit about the results. And ultimately, the topic today is something that I'm super passionate about in the realm of the organ work, because it's something that, like many of the symptoms that I treat, but this one specifically, it's something that I see often, but I wish that it was more often, because ultimately what I'm talking about today, many people live with these symptoms and just kind of blow it off and say, oh, it's just a part of life. It's no big deal. I'm just going to kind of throw this at it or throw that at it and just kind of see what happens and just live with it basically. And the reality of the situation is that there is so much that can be done. There's so much that can be done, especially from the visceral lens or from the visceral manipulation perspective. So without further ado, today we are going to be talking about GERD, aka gastric reflux or acid reflux or heartburn, whatever way you talk about it. It's whatever name you give it, where it's kind of boils down to the same number of things going on. So we're talking about acid reflux today. Again, it's something that many people struggle with. I will say primarily in the older demographic. However, I've been seeing it in younger and younger populations, which is interesting. But many people live with symptoms of acid reflux and just throw Tums at it or avoid eating spicy foods and just call it a day. And again, there is so much that can be done. So today is going to be kind of my brief step into, or kind of introduction into, some of the stuff that I do in terms of the realm of things that can be done to address these types of presentations, these types of symptoms. With that being said, I can only touch on so much. Otherwise, I would be talking to you for hours and hours and hours. So I'm going to try to keep it as, I won't say as brief as possible, but I'm going to basically work on keeping it specific, the things that I saw specific to this patient case. And then I'm sure down the line, I'll be able to extrapolate on other aspects of addressing GERD or acid reflux, or fill in the blank with your preferred terminology. So let's go ahead and get started. The patient case. Okay, so this is a 32-year-old female. 32-year-old female has been struggling with acid reflux for the past 4 years. All right, so pretty chronic history of on and off acid reflux symptoms. She has identified that it is associated with certain foods, or she notices that certain foods are definitely a trigger for symptoms. And you guessed it, primarily spicy foods and Chinese food, interestingly enough. And she has also noticed a link to her stress. So this individual, she works a pretty high stress job, is pretty kind of go all the time, not a lot of rest time, working over, 40 hours a week. Excuse me. And she notices when she goes through seasons or periods where she is a lot more stressed or there's a lot more anxiety, her acid reflux is worse. So definitely already kind of starting with some interesting points. She essentially came to me after seeing her primary care physician. She saw her PCP, was asking about, her symptoms, what else can be done, and her PCP recommended a new prescription medication, or new to her prescription medication to address her symptoms. And ultimately, this patient kind of paused for a moment and said, you know what? This is great. Thank you. However, I want to see if I can pursue something else before jumping on these meds, which I love. I think that that's awesome that she opened up her mind to kind of pursue some other options. Ultimately, because, and this is a little side caveat, because this is a whole nother rabbit hole that I can dive into, but some of the mainstream medications that are prescribed for acid reflux, specifically the PPIs or the proton pump inhibitors, very, very commonly prescribed in these situations. I have seen where patients have been on them for many, many, many years when it should originally have been months, if not a month, and then there should have been a resolution of symptoms. But patients have stayed on these medications for years, and there becomes a point where this is potentially causing more harm than good, okay? Causing more harm than benefiting the patient. And after, prolonged use of PPIs can actually start to create a disruption of actual stomach pH balance, and the acid in the stomach then starts to not be able to do what it's got to do. So you're starting to have an impact on digestion, especially those initial stages of digestion as a whole. So again, starts to do a little bit more harm than good. And we don't want chronic use, ideally, of any medication. Again, obviously there's going to be situations in certain cases where that doesn't apply. But with PPIs, we definitely don't want prolonged use of those, or chronic or even a lifetime use of those medications. So with this patient, I was very, very excited that she came to me prior to starting those medications, also because it gives us a cool window of opportunity to see how do these intervention techniques, how do these manual therapy techniques impact you without the influence of those meds. So really, really cool opportunity for us. So again, 32-year-old female, 4-year history of acid reflux, kind of on and off. She already notices a link to certain foods, and she already notices a link to stress. Okay. So already kind of starting to dive into some interesting aspects of, going kind of beyond just a certain system that's involved. When you start to notice an influence of things like stress and anxiety or different emotional states, you have to consider the neurological input to the area, obviously the emotional implications of what's going on, and how the body's response to stress as a whole, how the body really manages that. And there's a component of that that's hormonal, right? Because cortisol, it is a stress hormone, right? So there can be a massive hormonal implication in what's going on with the acid reflux as well. So again, I'm saying that just as like a tidbit of trying to bring in this kind of thought process of expanding mindset to think, okay, what are the different systems of the body that could be impacting what's going on? So already we're starting to have nervous system, we're having a little bit of limbic system with the emotional impact of stress and anxiety, but then also some of the endocrine or hormonal system. Okay. So already those 3 systems you might have never even originally considered having an impact on acid reflux. Okay. With that being said, maybe before I kind of dive into the more objective or evaluation pieces of what was completed with this patient, I want to talk about, from the visceral perspective, other systems that I'm already, when I hear acid reflux, that my brain is already like, okay, we got to look at this, and this. Okay. The first one is going to be pressure regulation in the body. Okay. Ultimately, the anatomy that's involved with acid reflux. So you're thinking the stomach, you're thinking the esophagus, okay? And actually not really the heart, right? Even though we think of it as heartburn, it's mainly because of the anatomical proximity between the esophagus and the cardiac sphincter, which is the sphincter that controls, or is that kind of bridge between the esophagus and the stomach and controls the flow of food into the stomach. There's a lot of proximity between the heart and those structures, but the heart itself is not actually burning, in case you weren't aware. But you get that sensation because of that backflow of stomach acid into the esophagus, that kind of burning sensation. So with that being said, you're thinking about the anatomy that's involved. Okay, we have the esophagus. I mentioned the cardiac sphincter. You have the stomach, okay, in the body where that's oriented. All right, the esophagus is obviously coming from the mouth, down the neck, into the thoracic cavity, to the diaphragm, and then attaches to the stomach, which is right below the diaphragm. Sorry, excuse me, I have a little tickle in my throat. Let me grab a glass or a sip of water. Excuse me. All right. I've been talking all day, so by the end of the day, my throat can get a little hoarse. Okay, where was I? So we're talking about anatomy. All right. So with pressure regulation, you have to consider the fact that the esophagus travels through the diaphragm to attach to the stomach. All right. So there's actually a physical hole in the diaphragm where the esophagus travels through to then attach to the stomach on the other side. Okay. The pressure systems that exist within the body, so above the diaphragm in the thoracic cavity and below the diaphragm in the abdominal cavity, have to be well balanced in order for there to be a normal distribution of pressure and tension across where the esophagus attaches to the stomach. Okay. So the reason I'm bringing this up is because ultimately, that hole in the diaphragm where the esophagus travels through becomes becomes an area of high potential dysfunction because of all the different factors that are playing a role at that area. Again, there has to be this kind of perfect distribution of pressures and tension across the diaphragm and in the thoracic and the abdominal cavity so that there is a balance of stresses in that region. And when there's an imbalance of the pressures within the thoracic and the abdominal cavity, that region of the diaphragm is very susceptible to increased stress, which ultimately is going to impact the function of the area as a whole, but also the function of the structures within the area. So you're thinking diaphragm, esophagus, cardiac sphincter, and then the stomach ultimately. Okay. So already we're starting to kind of draw in the potential for a lot of tension in the body kind of impacting this region. Okay. With that being said, back to the pressure gradient situation. The thoracic cavity has to maintain a negative pressure for the lungs to work, and then slightly below the diaphragm and to the top of the abdominal cavity, it switches to a slightly positive pressure. So again, there needs to be a balance between those in order for those systems to orient themselves well to each other. If there's a disruption in that, it can create problems. Okay. Those pressure changes can be caused from anything from past infections to surgeries where you're kind of opened up to atmospheric pressure, to physical trauma to the body. Really anything that kind of has the potential to create inflammation has the potential to create a disturbance in those pressure gradients. All right, so that's one of the areas that I consider is, okay, what does the pressure management system really look like? How is the diaphragm really functioning in its role in that? And then also, if you really want to tie it all the way around, you have to think of the pelvic floor as well, because the diaphragm and the pelvic floor are massive managers of those pressure systems. Okay, I'm not going to go too far into the pelvic floor stuff. Not yet, at least. Not in this episode. But those are kind of where my mind starts to go. I also am going to start to consider the mobility of the digestive tract as a whole, because ultimately the esophagus and the stomach are those initial components of the digestive tract. All right, because we consume food travels down the esophagus. It's moved along with those peristaltic waves, which are basically little, rhythmic wave pattern that moves food down towards the stomach. And then food passes through the cardiac sphincter into the stomach before then going into the small intestine. So tension, even in a distant part of the digestive tract, even in the colon, right, has the potential to create a lack of mobility that impacts all the way back up to that esophagus, to the stomach, to the initial part of the digestive tract. So I'm always going to be considering how is the entire digestive tract as a whole really moving and gliding and sliding in relationship to one another. Okay. Another area of consideration in this situation is going to be the musculoskeletal system, because like I've talked about in the past, organ movement is obviously important in regards to how organs move in relationship to other organs, but also how they move in relationship to the musculoskeletal system, to the spine, to the ribs, to the, so on and so forth. Okay. So because of the orientation of the esophagus through the thoracic cavity, it's very posterior, it's very deep, right? It runs behind the heart, behind the lungs. So you have to consider thoracic spine mobility, because ultimately that's where that esophagus, that tube kind of follows, right? So you have to consider the mobility of the thoracic spine, so the mid-back. With that being said, you're also going to look at the cervical spine, because again, the esophagus travels through the neck as well. So I see a lot of individuals with chronic neck pain or chronic neck stiffness that it's actually tied back to the esophagus. They might have chronic neck pain and also heartburn, and you're just thinking, bam, that's like literally lining you up for that's in my brain. I'm like, 2 + 2 = 4. So we're looking at the esophagus and the stomach and the digestive tract, okay, so on and so forth. I digress. But you have to consider the mobility of the musculoskeletal system and the impacts that might have on the organs deep to it. Okay. So those are that's kind of where my brain goes initially before I lay my hands on this patient. All right. So when it comes to the evaluation piece, those are the things that I'm I'm at least initially going to evaluate. So we're going to look at cervical spine range of motion. We're going to look at thoracic spine range of motion. I'm even going to look at lumbar spine range of motion just to kind of get a good collective picture of all of it. If I really want to be fancy, I'll look at TMJ mobility, but again, that's another whole rabbit hole. Looking at jaw mechanics. But again, looking at spine range of motion. All right. I'm going to look at rib cage range of motion. That's going to start to give me more information about the diaphragm as a whole. So I'm going to see, okay, are the ribs really expanding and rotating the way that they need to? That really indicates balanced lung mobility, but also diaphragm mobility. You want it to be balanced on both sides. For this patient, I will say there was limited thoracic rotation to the left, and there was extremely limited rib expansion and rotation on the left side. Okay. So already picking up some pieces of information there. Next, I start to analyze kind of organ movement. So overall, I'm going to look at system tension in standing. I'm going to look at it in seated. I'm going to look at it in supine, so the patient laying on their back. I'm going to start to appreciate differences between left and right, looking at kind of fascial loading into the body to see if there's any sticky points, basically. And then again, going to assess the diaphragm, some of that mobility in supine as well, with just some different compression strategies or evaluation techniques. Ultimately, through my evaluation, again, we have the orthopedic findings of limited left thoracic rotation and limited rib expansion and rotation. on the left side. I don't know if I said that already. And then organ wise, okay, so assessment of organ systems. I'm already suspicious that there's going to be something in the thoracic cavity because that's where I'm finding more of the musculoskeletal limitations. And sure enough, I find that the left lung literally has no mobility, pretty much does not like to move. Okay, so the lungs need to be able to, again, just like anything else, needs to be able to move and glide and slide. There's not a huge area for it to kind of move. It's not like the small intestine where it has the whole kind of lower abdomen or the whole abdominal cavity to kind of migrate around. But you can still appreciate how the mobility of the lung really, you can still appreciate how it is moving in relationship to the rib cage and into the heart. So already finding a lot of tension on that left side of the thorax. So looking around the lung, looking at the pleural lining around the lung, looking at those fascial connections around the lung, and not seeing a lot of mobility. Okay. And then the diaphragm is really limited on that side as well, which is not a surprise. And again, in case I didn't mention this earlier, that little hole in the diaphragm, again, the hiatus, or where the esophagus travels down through the diaphragm to attach the stomach, is more on the left side. All right. So you can imagine, all right, if you were to like clamp down on like the whole upper left thorax, like right now I'm just kind of like hugging my left rib cage basically to my side. If I even try to breathe like that, it's super uncomfortable on the left side. Like you just don't get a lot of mobility there. And if you can imagine, like if all that's kind of clamped down and not moving well, then it's going to impact a lot. Like the esophagus is not going to be able to move very well. The diaphragm definitely does not move very well. And then the stomach, which is right underneath the diaphragm on the left side, is obviously not going to get a lot of mobility either. So you're really setting up the system for the potential of a lot of dysfunction. All right. So treatment-wise, I addressed the limitations that I found. Started out with working through some of the increased tension in the left side of the thoracic cavity. So looking at, again, some of the fascial limitations, treating that. Treating some of the pleural limitations, again, with the visceral techniques. Making sure to improve the mobility of the left lung as a whole and balancing that to the right side, because ultimately the goal with all of this is to create balance within the body. All right. And then starting to integrate that into, okay, how can we improve diaphragm movement, especially over on the left side? So doing some treatments on the actual diaphragm itself, opening up through the left aspect of the diaphragm because it's like basically just kind of like anchored down on itself. And then I'm starting to look more at the digestive tract as a whole, making sure that the stomach is moving and gliding and sliding. So I assess organ mobility very similar to musculoskeletal mobility. I want to make sure that it moves in all planes of motion. So I'm making sure, does it move, inferior, superior? Is it going left to right laterally? Is it rotating on itself? Does it have the freedom of all those planes of motion, and then treating where I'm feeling those areas of tension, those stickiness. So it's very common in individuals with acid reflux or with heartburn, with GERD, is the stomach does not want to move inferior. It's really stuck up underneath the diaphragm. And it's just it's like used to just being tight, like being pulled towards the esophagus. And so when it doesn't have the ability to stretch down, acid reflux is going to more than likely, it doesn't have a lot of places to go. So it's going to go up. Okay. Because that's kind of where the stomach is stuck. All right. If you can kind of start to imagine that. So I'm working on, okay, how can I create some relaxation around the stomach and some kind of stretch along the top of the stomach and the esophagus to allow the stomach to relax down away from the diaphragm so that it's not continuing to aggravate up. Okay. Does that make sense? I hope that makes sense. So that's really what I worked on. Okay. Pretty simple as that initial session. Again, this is my first time seeing this patient. Addressed a couple areas of limitation. And then I made sure to follow up with some movement. Just like any typical physical therapy practice, we worked on good diaphragmatic breathing. So I like to use an exercise called 360-degree breathing, which works to engage the diaphragm in its entire circumference. And then we worked on, or actually we had a discussion, I will say, about something that I think probably had one of the biggest impacts on this patient's symptoms. I mean, don't get me wrong. Obviously, the manual therapy stuff is going to have a pretty amazing impact. I mean, already after the techniques, I'm seeing improvement in rib expansion and rotation, seeing an opening of the diaphragm on the left side to create more balance between the right and the left. So the movements were actually more synchronous as opposed to the right side expanding, the left side not. And then she no longer had stiffness with that left rotation. There maybe was a small limitation at like end range, but it was significantly improved from where it was before. She was stuck. It was kind of uncomfortable. And now she was able to gain more of that mobility. So already seeing those physical signs of improvement in the balance of tension within the body. And then something else that this patient and I discussed is, with her high stress job where she's moving from meeting to meeting to meeting to call to call to call, not having a lot of breaks or time to sit down, she eats super, super fast, literally has 5 minutes, shoves food down her mouth, and then moves on to the next meeting. Like no time in there to really take a moment to step back and, eat or let the body do what it's got to do in order to start the digestion process. And ultimately, that was a huge area for us to create some potential for significant change that's going to last for this patient. Because if you when you slow down the eating process, when you take your time really eating your food and chewing your food well, you're literally priming the digestive tract to digest efficiently. So not only are you going to reduce stress on the stomach, right? But you're also going to reduce stress on the digestive system as a whole. So you're going to see less bloating, less cramping. You're going to see better nutrient absorption. You're going to see better elimination, better bowel movements. Not only do you get all those benefits in the digestive tract, but you're also going to improve vagus nerve health. Okay. And I'm sprinkling that in with the promise of talking about more of that later because it's such a massive impact. But when you slow down and chew your food well, you're benefiting the vagus nerve, you're benefiting the digestive tract, you're reducing stress on the esophagus and the stomach. And so creating a really profound opportunity for some significant change, okay? Especially when acid reflux is the response to eating, okay? And then you'll get some nervous system impacts with all of that too, some benefits there. So that was really, really huge that we got to identify that and then ultimately encourage that patient to give herself a little bit more time to slow down and to actually eat, and ideally to reduce any kind of, distractions while she's eating so that her body can really focus on the kind of stepwise process of digestion. Okay. So that was really, really huge. So in terms of the results for this patient, so again, this is all session number 1. All right. I send her home with my, in the PT world, we talk about HEPs. So home exercise programs or home exercise plans. Hers was to work on diaphragmatic breathing. Okay. So to work on not only mobilizing through the diaphragm, but also the rib cage, the spine, and then also starting to address the pressure system stuff. But also her second exercise was to eat slowly. So not necessarily your typical HEP or exercises from your physical therapist, but ultimately patient goes home. I see her 2 weeks later. And I didn't mention this before, but in the symptom, when we were going through her history, she was telling me that she was using Tums 2 to 3 times daily to address her symptoms. Tums 2 to 3 times daily to address her acid reflux. 2 weeks after I see her, she comes back in. She had used Tums 2 or 3 times total in 2 weeks. I mean, that's huge. That's huge. So powerful. So freaking cool to see how quickly her system responded to just a little bit of input to, again, kind of create that window of opportunity for change and for balance and for restoration of typical mobility within the organ systems. And to see that have such a drastic impact on her symptoms was incredible and so unbelievably encouraging that, again, things can be done in order to create change beyond medication, beyond surgery, beyond, fill in the blank. Okay. Really incredible possibility and potential for change. So that was really, really exciting. And with that being said, her body had maintained some of the changes that we made. Her rotation was still well balanced. There was a little bit of a change, still a little bit of stiffness in that left rib cage mechanics, but overall better than how it was in the beginning. And then, of course, we kind of get to start diving into some of the other things that were going on, some of the other factors that were impacting her symptoms. So really, really profound. Really cool to see, again, how quickly changes, even like just little changes here and there start to make such a big impact for her, kind of giving her back some of her life, which is really exciting. And, of course, a big piece of that was her being able to implement some of those lifestyle changes, like the ability to really engage through the diaphragm, the ability to slow down and really chew her food well. She said, and just like anything, she wasn't perfect at, incorporating that into her life, which is very normal. I mean, I'm not expecting people to be 100% perfect at these things, but even just that subtle kind of reminder, that subtle change to slow down, just really, really cool to see that. I will say this just really quick, back to the vagus nerve impact on the impact on the vagus nerve with eating slowly. It's only going to help improve that relationship between increased stress and anxiety and the acid reflux symptoms. So it was really cool. And now that I've seen this patient for, a handful of sessions, is we're seeing a reduction in the reactivity of her acid reflux to higher stress environments. In an ideal world, we'd be able to remove the stressful environments or the anxiety-inducing environments from her life. But the fact is that's not reality. But what we have been able to do is re-educate the body, or create an opportunity for the body to create some positive change and reducing that reactivity to those stressful environments. So really, really incredible to see how her system is responding to the work. And of course, as I'm biased, but so cool as a provider to just be affirmed in the work that you do. So all the way around, just it's so powerful to see that, to witness that, and then to be able to work with people and create meaningful changes in their life. So with all that being said, my encouragement for you, if you are experiencing any type of GERD symptoms, any acid reflux or heartburn, or maybe you have some GI stuff and you have some back pain or like some neck pain or some stiffness, and maybe you experience kind of difficulty swallowing, or maybe if you feel like you'll swallow some supplements or something and it gets stuck. Those are kind of indications that there is some tension that's impacting the mobility and the function of those structures that I've been talking about. So seek out help. And with that being said, by all means, you're welcome to reach out to me, leave a comment, send me an email, give me a call, whatever it is, to see if this work would be beneficial for you. Or if you need help finding a provider in your area, please, please, please reach out, because ultimately there's so much that can be done. There's so much, so much. So with that being said, let's wrap it up. So I want to end all of these sessions with what I'm going to call a healthy organ tip. I don't think I said that at the beginning of today's episode. So this is me letting you know that all of these, patient discussion cases, I want to leave you with a healthy organ tip of the episode so that you can leave ideally feeling a little bit more empowered about something, or a little bit more educated about something that you can implement in your life, a lifestyle change that you can make that is going to promote healthier organs. Okay. So the healthy organ tip of today is to eat slow. Okay. Eat slow and chew your food well. It's only going to prime the digestive tract to work better, to work more efficiently for you. Digestion we can even go back to digestion starts with you even seeing your food, with you smelling your food. So take time to take it all in. Truly smell the roses, aka smell your food. I mean, when you prepare a meal, the process of cooking is sending signals to your brain that, to prep for what's coming. And so because of that, then it's able to let the stomach know, okay, hey, this is coming. You got to, step up your job. And then letting the small intestine know, hey, in a couple hours, like you're up next. Just the whole process is primed when you take time to take everything in. So take in your food with your eyes, look at all the colors, smell the food, smell all the smells. And then when you are starting to ingest your food, take your time, eat slowly, and chew well. Like I like to think like chew it until like it's like a mush. Okay. Because if you can imagine swallowing a piece of steak whole versus chewing your steak really well and swallowing it, what do you think is going to be easier for your stomach to break down? Okay. It's not a hard question. So chew your food well. Your body will thank you. Your stomach will thank you. Your digestive tract will thank you. All right. So there is your healthy organ tip of the day. So with that being said, thank you for being here and for listening. And I'm looking forward to next time. See you soon.